I'm delighted to welcome, I can see she's already here in the audience, so if we could bring Amanda Begley onto screen with me, I'd be very grateful. Here she is, Dr. Amanda Begley, the one and only Executive Director of Digital and Transformation for Health Innovation Network South London, and also, dare I say it, Amanda, you're also still a member of the GSTT community, I believe. I think that's correct.
Yes.
You're with the Health Innovation Network on secondment. Guys and St Thomas's, any of you in the audience today, you are, of course, our regional hub for London. Always a fantastic relationship we have with you. And Amanda, we're so grateful to you for coming along to partake in our keynote this morning. Do you want to just give us, first of all, a little, just because we've got people who will be very interested, give us a little potted history of how you've come to be involved in this business of innovation and digital and tech and so on. How have you become so involved in it? What's your sort of backstory?
Anyway, good morning, everyone. I have been sipping my tea and I've noted down your framework, John.
Thank you. I hope you haven't had a mince pie. I mean,
no, I haven't. I've had my porridge, though. I've had my porridge.
Porridge.
Yeah, so I joined the NHS in 1999 as an assistant and then trainee clinical psychologist. And I was faced with sort of a year and a half waiting list. And that was quite demoralizing, and felt that I was then supporting people to manage a habit and way of life rather than helping them to, improve really. And so I then I suppose I was interested in how on earth I was in this position. So then took a secondment and went into commissioning, having sort of looked it up in a dictionary to try and find out what it was.
And by the way, everybody did. As soon as clinical commissioning groups were announced, everybody started looking in the dictionary.
What's that about?
Yeah.
So, and then worked what was then in a primary care group, which turned into a primary care trust. And I just volunteered for everything. So I was I suppose, eager to learn. So I've always been quite eager. I find learning really energizing. I also get quite frustrated. So I used to think, I wonder I wish I could do that job because I wouldn't do it like that. Not to say that I thought I could do it any better, but it just frustrated me because it was impacting, like the commissioning was impacting on my job and doing what I felt was the right thing to be doing. So I think that often drove me. I never had a career path at all. I just used to think, that looks a really interesting job, or that's really frustrating, or I don't know enough about that part of the system. So I think I've also always been really interested in the fact that we operate within a really complex system. And when I worked at in commissioning for a number of years, but also then managed community services while I was there. And did a lot of work with primary care around introducing new contracts and helping them with their introducing of IT, which is interesting because I remember going to one GP practice where the doctor was holding the door open with a laptop on the floor.
Brilliant.
Oh dear.
Of course, that would never happen in 2024.
Well, who knows? But yeah, a lot of work in primary care, a lot of work with community services, a lot of work in commissioning, and then I was asked to lead planned care. So shifting of activity out of hospital into the community. And I used to go and have a conversation with the consultants at the local hospital, and then I'd come back to the PCT and go, they don't think it's safe. They don't think we've got enough staff and resource. And they'd say, so sweet, she's so naive. Of course they say that to you, Amanda. They don't want to lose their money. And I thought, I've never worked in a hospital. I don't really know what it's like, what they're dealing with. So then I applied. My nan then was admitted to the local hospital, and all my family went, "You work in the NHS. What's going on? You must sort this out for her." So, and then I opened my IHSCM, and there was a job for a divisional manager in my local hospital. So I just applied. And once again, that was about, I don't really understand that part of the system. I find it a bit frustrating about why we're not able to shift resources. So that sort of drove that. And I've been very fortunate to always love my jobs, very kind of 24/7 on site, operational management, firefighting, working with phenomenal people, And then I had my little son and thought I can't actually be on site 24 hours a day as much as I'd like to.
Yeah.
And so I was offered a role of head of innovation at what was then Strategic Health Authorities, who were given a legal duty to innovate, which is a very interesting reason to innovate. And that made me think actually all of my career has been about, being frustrated with problems, trying to find solutions, trying to understand how the system works or doesn't work. And so that then felt like the right thing to be doing. And then since then, I've been very much focused on sort of innovation and transformation, particularly across the system.
Yeah.
So working across primary, community, secondary care.
It sounds to me as though your career's really been more about curiosity.
Yes. Yeah. Curiosity, learning.
Yeah.
Frustration.
And kind of you followed that curiosity itch, really,
Yes.
as your career's progressed. And you thought, oh, I wonder if, and it's served you well, hasn't it? I mean,
yes.
I suppose
I've been very lucky.
Anybody well, actually. Well, okay. What I want, you and I had a bit of a chat last week to kind of brief ourselves on this. And one of the things that we hear from our members, and most of the people on the call today will observe too often for comfort, is that there will be a sparkling, shiny, effervescent new thing that is introduced into their particular area of healthcare, and it may be a relatively tiny part of healthcare, and it may even do exactly what it's supposed to do and improve effectiveness or drive an efficiency in that particular block. But what it inadvertently does is create actually quite significant problems further along the pipe, either because it adds to demand, creates some kind of a log jam, or because it's not been designed from a system perspective. It's just one of those shiny things that we'll all remember Matt Hancock when he was unfortunately Secretary of State for Health and Social Care. He kind of, he was like a child in a sweet shop, just picking bits and bobs that kind of took his eye. Amanda, talk to us about how do we do whole system innovation planning, and how do we, I mean, we could spend hours here talking about all the fallibilities about what's going on at the moment. Do you have any kind of a vision or plan or strategy for how we better do whole system innovation planning and introduction?
Yeah, I mean, when we met, John, we talked about the reconfiguration of stroke services in London, and very, fortunately or unfortunately, depending on how you look at it, I was working at UCL Partners.
Dame Ruth.
Dame Ruth. Yes, I was actually at the Health Authority, but also then had gone on secondment to UCL Partners, which was then a academic health science centre, and subsequently has moved into being a health innovation network as well. And so we were leading some of that engagement and support work, working closely with Ruth. And for people that aren't aware, this was really around actually Aradazi had been asked to do a review of London services to understand where we were at and opportunities for improvement and innovation. And he particularly identified stroke services across London as an area where we needed to significantly improve, because we weren't able to provide 24/7 care, evidence-based care, particularly thrombolysis, in which you have to deliver it within a set number of hours if you're really going to change the morbidity and mortality of somebody who's had an acute stroke. So at the starting point, what we had, and I think is always really important, is a compelling case for change. So we'd really understood what the problem was, and it had been articulated by somebody who was very credible and respected, and had been articulated through review of the evidence and performance and a lot of engagement. So we knew we had a problem. It was out there and published that we were failing to deliver the best possible care we could for Londoners. And then what was happened is a clinical, multi-professional clinical team were brought together to say, what what should our services look like? And they proposed that we would move to a system where we had hyperacute stroke units. We'd have 8 in London, and they would provide care in the first 72 hours. And then we would have 24 acute units that would pick up patients' care for the next stage of their care pathway. Which, but when you look at the sort of volumes you need to have, when you look at the sort of diagnostics, the specialist capability you need on site, you need a certain amount of volume in order to deal with those first 72 hours. That made a lot of sense. But what it did mean is that a patient would have to go past 1 or 2, maybe more hospitals to get to one of these units. A paramedic crew, with their very tight performance metrics about how long they had to have to get to somebody and get them to hospital, would have up to half an hour, and also have to drive past these different hospitals to transfer a patient. There were implications for training for our medical students. There were implications for the fact that there would be some trusts would lose those services and lose the income associated with it, and some of those were performing organisations. So there were lots of things that we knew what the implications were, but we had identified those at the outset by having the right multi-professional team thinking through what would be the unintended consequences of this, and who would it impact. And then in terms of the sort of the way that was approached, it was very much extensive kind of consultation and engagement. And as you can imagine, particularly with Londoners, about how they would feel about themselves as a patient, and also their families having to drive for up to 30 minutes.
Yeah. Exactly.
Not being dropped off at their local hospital, which they know and love and feel very comfortable in. And that their families would then have to go that extra mile, 30 miles, to get to that, to see their family members when when they'd just been diagnosed with a stroke. But there was acceptance by the public about that, lots of engagement, and people understood why, from a clinical and safety perspective, that was the best thing to do. There was, as I said, lots of multi-professional engagement, and they very much drove what was the best care. There was a very sort of strict process of defining a specification for those 2 types of care, so the hyperacute and the acute stroke units, and a procurement process, open, transparent procurement process, where everybody could put forward what they wanted to be and why they had the services in place. Really strong governance. So there were 2 governance boards that oversaw not just the sort of decision making on the procurement, but the setup of those services and the performance management of them. And there was also some money, which is always really important, particularly when you're changing services around, and some would lose some money and they needed to be kept afloat. So there was 20 million that the Strategic Health Authority made available, which actually is a pretty small amount when you consider the budget for London.
And you could regard it as an investment as well.
Yes, absolutely.
Rather than just a straight spend. I mean,
yes,
you're going to get this back, basically, aren't you?
Yes, yeah. And we're going to save lives, which is always, the most compelling reason for driving change. And they were also set in some new kind of performance measurement and sort of financial incentives to drive up performance. And what we found actually only within sort of a couple of years was there was a 25% drop in mortality, 6% improvement in sort of reduction in spend. There was an increase in clinical trials, which we hadn't anticipated, because suddenly you had a lot of volume for that first 72 hours, but also for the post 72 hours. And so it became a fantastic site to bring in income and activity from clinical trials. It also had driven a lot of connectivity between primary and secondary care. So people came together as a community to drive this, and those relationships were established and continued. So also some of the unintended benefits of this change in the system. But yeah, I think for me, that was one of the most sort of significant, London-wide change programs that I was fortunate enough to be involved in. And as I said, I think
what I'm hearing there is that we start with a problem rather than start with a shiny thing that has a lot of appeal and perhaps quite a clever sales person trying with a rather sophisticated PowerPoint slide deck. Instead of that, what we're actually doing is we start with a system problem, and we get a multidisciplinary team together, and we engage with all stakeholders to say, okay, any innovation is available to us and is on the table, and we rule nothing out, but let's start with what do we need to do to fundamentally address this problem. If that involves some shiny bits of kit that we know about, terrific, but that's not necessarily the start point here. Would that be a fair summarization of what you've just said?
Yeah, absolutely. Absolutely.
Okay.
Don't start with a solution.
Yeah, exactly. And yet, you know, we employ salespeople the world over, and that is their, you know, principal responsibility. So it's just interesting. Start with the problem. And even now you can look around the health and social care landscape. There are problems galore.
Yes.
But how often are we honestly, hand on heart, starting with saying, how do we fix the problem? And then let's find innovations or even design innovations that actually contribute to the solution. That's interesting. So if we may move along a little bit, because I think you've given a pretty strong answer to the first bit about how do we do whole system planning. May we talk about the successes around the country? And obviously you've got some specific experience around South London and the Health Innovation Network there. But when we talk through our, for example, our digital technology special interest group people and so on, they often say, do you know what, why do I find it so difficult? If actually we've innovated in a particular local area, why do we find it so difficult to then scale that when it's demonstrated its capability? Why do we find it so difficult to scale that to a much wider adoption across social care or NHS or whatever else it may be? I would love to have your comments and feedback in that regard.
Yeah, I mean, it's a really challenging issue, isn't it? I think the move towards integrated care systems from what were very small clinical commissioning groups allows us to deliver more at scale. Certainly with the hyperacute and acute stroke units, it was because we had we had a whole region working together that meant that it was all changed at the same time, which is, I know, a very rare element. There are some examples. So it's worth having a look at the Health Foundation. They funded, I think it was 2021, they funded some innovation hubs who are trying to deliver change at scale. And I know the Dorset one has quite a lot of information on their website about the elements they're putting in place to try and deliver at scale. I think there's sort of, I think my sort of reflection on the things I've been involved in is it very much depends on the nature of the change that you're trying to make and who's involved, about the approach that you take. So on the sort of NHS Innovation Accelerator that I set up and ran for a number of years, we had I suppose a number of sort of things that really almost switched the dial from something being in a small amount of areas to being more spread, and those varied quite a bit. So we had iThrive, which was a mental health innovation that was supporting children and young people, and they had spent a lot of time building their evidence base. They had great very credible clinical leadership. They'd gone to loads and loads and loads and loads of conferences, but you got a little bit of money through the Health Innovation and through the NHS Innovation Accelerator. So I suggested, why don't you run a competition to sort of go out, you've got a bit of funding, run a competition and say, we're looking for 10 sites across the country. You'll all get, so it was something like 7 or 8K. It wasn't a huge amount of money. And we've developed all these tools about how you implement these things, and we'll come and help you do it. Come forward if you want to be part of this competition. And people do love winning a competition.
Okay. don't they?
So lots
And
of
the
comms and
skirt of genius
marketing.
moments, you've no idea how proud that makes people feel, you know?
Yes, exactly. Really hardworking people that can win a bit of money, get profile. So, we'll put a lot of comms and marketing behind it. We'll get you out in front of people. So that was effective. And actually they are now in something like 80%, it's, at least their principles of iThrive are something like 80% of mental health services across the country. I know Patients Knows Best, which a number of people might be familiar with, but back in 2015, the vision of let's give patients their care records was really quite advanced for us back in 2015, and everyone was very much bought into the mission. Yes, we must involve and empower patients. Let's give them their records. I've got no way of paying for this, but really keep going. Your mission's brilliant. So what they found through lots and lots of conversations was, although the organization kept their mission very firmly as their mission, what they found was the way to get it into practice was to say, this is how much I'm going to save for you in print cartridges, paper, postage. And suddenly you started seeing quite traumatic, quite extensive spread across the country of that innovation. And so it's quite another innovation, AcuPebble, which is a really nice little device that allows you to diagnose sleep apnea in people's homes, because we've got huge waiting lists. It's very resource and expensive to bring someone into hospital to 1 or 2 days. A lot of people can't do it because they don't want to lose their job. They have caring responsibilities, so they've developed this little device. You put it on, it just gets stuck onto your neck. You don't need to have internet connection. It can all manage, they collect the data without that. And you sleep with it overnight. You might have to do a couple of nights, and then you just take that device in to the hospital, and then they can analyze the results. And once again, they spent a lot of time building the evidence base, working with Royal Free Hospital. But what I think was very powerful about their work was that they were very passionate about inclusivity. So they really understood the population that they were trying to serve. So, for example, sleep apnea is more common amongst people who are classified as obese, and people who are obese often sweat a lot at night. So they really had to think, how do we make sure this adhesive meets the needs of these populations? And they also identified that people with Down syndrome sleep apnea is much more prevalent in that population. So they were doing a lot of work around, is this acceptable and feasible for people with Down syndrome? And so when you have an organization that's very mission driven, the NHS is all about people. We're all working hard trying to do the right thing. And when you're working with an organization that has that at the heart of their mission of inclusivity, and how do we make sure if people don't have Wi-Fi at home, they can still use this? How does it really serve the population that we know are really struggling with this? It does engage people more. They are more likely to engage with these organizations and take up these technologies and try them. So I suppose that's a few kind of examples. I can go on and on and on, Jon, as you know.
Well, no, it's interesting. I mean, there was some rationale to starting today as the early bird thing with how to manage up, because it's all about it's not about selling your technology. It's about winning the trust of the people with whom you need to work in order to achieve a set goal that you share. So it's not about you winning and they bought something. This is about, how do you achieve a shared goal around a specific problem that we're looking to jointly resolve? And how does my technology or system improvement change positively contribute to that? Because I understand the perspective that you might be coming at this from. And that's the key when you explain, right, at the moment, as the way I see it, you're doing it like this. This is the effect that I think that has. Help me understand whether I'm wrong or not. Because we're all trying to achieve the same thing here, and I come in peace and I mean you no harm. And it's that kind of mindset I suspect that we have to cultivate if we're going to achieve spread of innovation at scale. And I'd be interested in your comment just on that one, to be quite honest.
Yeah, I think I do. I think that it's absolutely a team sport.
Yeah.
So if you're going to anticipate what the unintended consequences are, as we've already talked about, if you're going to really understand the barriers to things being taken up, you need to make sure that you have conversations with all of those that are affected, particularly users. In some cases, that are as patients, carers. In some cases, that's our staff, colleagues. So really involving our users and understanding that, have I designed this in the right way? Have I really thought through what the impact might be on different people? And you've got to include finance in that, IT in that, our operational manager, our administrative team. So really making sure that you're understanding it from different people's perspectives, and also that you're bringing that skill set and brain into the work that you're doing, and also creating allies, because it's really lonely trying to drive change. And your resilience comes from people who are part of the team and driving things. I think the other thing that I've found gives me some confidence, but it's not for everybody, is just the academic literature, if I'm honest. So you've got lots of frameworks like Trish Greenhow. So she came and spoke at one of our NHS Innovation Accelerator events, and I couldn't even speak to her because I was so excited. She was like, "Oh my goodness, it's Trish Greenhow." That's very sad of me, but I'd read so much about what the work that she'd done, and she's got a really nice NASS framework, NASSS, that helps you think through what are the barriers to this innovation being taken up, and how much time and energy do I have to spend on each of them. But you've got things like the normalization process theory, which has got a lovely online toolkit where you can ask a series of questions and come up with a framework for where should I be focusing my energy. And that's a bit more of a kind of behavioral, cognitive kind of psychology approach. You've got Susan Mickey's behavior change framework. The Implementation Science is a journal that's free, openly accessible. So, looking at some of the literature to give you some confidence in the framework that you're using, I found gives me confidence. They're all quite intuitive. You'll know all this stuff anyway, but it just makes me think, oh, and it's like things like implementation science is kind of based on, if you want people to change their behavior, they've got to have the motivation, the capability and opportunity to do it. And even that simple framework, okay, is this person going to be motivated? How do I motivate them? Do they have the capability? How much training do I need to provide? Have they got the opportunity? Can they manage up? Have they got the resources they need?
This is really interesting, because what we tend to do is we just rage. We become frustrated and we rage.
Yes.
And we declare about the inequality and unfairness of everything, instead of just saying to ourselves, you know what, I'm not trying to win here.
Yeah.
I just need to collect a collaborative group of people who we all share the same goal, and therefore we are probably inclined, if we work together sensibly, to figure out solutions whereby actually the at-scale thing is a no-brainer.
Yeah.
Just the idea of just doing it in a little locale may work as an evaluation study, but do you know what? Because of the commitment and allyship that we've developed, do you know what? You don't even need to sell this. It's intuitively a sensible thing to do.
Yeah.
And it was interesting. I loved the stroke story, about all the pushback. I remember at the time, all the pushback that was coming from all sorts of different, quite self-interested groups. And as soon as you remove the self-interest element, and you just come at it from actually, this is a big problem and it's killing a lot of Londoners that didn't ought to have to die. As soon as you come at it from that perspective, the self-interest thing rather gets swept away. And there's a virtue to it all of a sudden that is inescapable.
Yes, you want to be part of a good thing.
Absolutely so, yeah. Who wouldn't want to be? Well, look, we've got about 8 minutes left before we need to move to the first breakout sessions of the day. Isn't she super, everybody? Dr. Amanda Begley. Would anybody like to ask Amanda any questions in the context of innovation, whole system planning, how we develop solutions to problems? Here you are. You don't get a better chance than this, and I'd be delighted to hear from anybody who'd like to ask a question. By the way, there are 85 of you on this. It cannot be that nobody wants to pass this opportunity by. Rajesh, let's go to you first. If you'd like to unmute, please, and you are welcome to ask Amanda a question. Go for it, Rajesh.
Hi.
Yeah. Go for it, Rajesh.
Can you hear me?
We're struggling to hear you, I'm afraid, my friend. I'm so sorry.
Sorry. I'll just type in sorry.
All right, look, we'll come back to you. If we get the opportunity, we will come back to you. Just instead of Rajesh, would anybody else like to ask a question? Please shout out.
Yeah, John, it's David from West of England.
Go for it, David.
Yeah, hi, Amanda.
Hi.
I'm wondering, what do you do, which often happens if you've got a wee team or a set of teams who, even though they're next door neighbours, they really can't agree with each other. I'm talking local authorities here. I'm from social care. And you get a situation where they hold on to, we're very different.
Mm.
They're actually in the same geographical spot, and they know that they all agree that change is required, and they almost take a position of, well, if they are going to do it that way, we're certainly not going to do it that way.
That's a great question, David.
How do you
Yeah.
work
Over to you.
with those kind of bears?
Yeah, it's really difficult, isn't it? I think what I've found is that it's really hard to argue with the citizen voice. So starting off with, what do us, in your case, citizens, or it might be users, want, and you'll probably find there's commonality across the services that are provided across both of those. And it is, morally very hard to say, well, I don't care what our users want or what our citizens want. We do it like this, not like that. So I think I would, as we said earlier, maybe there is something around capturing insights, understanding the problem, and even doing some sort of interviews with different staff across those different organizations to to understand what the problem is that they're trying to solve, as a starting point to bring people together around a common problem. So that probably would be my starting point. And then finding ways, bringing people together, having sort of facilitation of events. I don't know whether you've got a local health innovation geography, because often we do help with kind of facilitating events, bringing people together, because I think if people spend a bit of time together around a common problem, they generally find more commonality across themselves than they do differences. But I know that can be very challenging in terms of making people come together and create time in their diary. So I would start off probably with some insight capture work around users.
Sorry, David, go ahead.
Sorry.
Certainly going to take away that change is a team sport, and the unintended consequences, I think, would be a good place to start. Thank you so much.
Sorry.
Lovely. Thank you very much, David. Just before we come to Hazel, Sababa asks, Amanda, are there any frameworks you use in whole system planning?
Yeah, that's really interesting. I'm not aware of any, but it sort of comes off as a bit, sure it isn't intuitive, but I would definitely look at, a lot of the stuff that I tend to look at is more the kind of barriers, enablers to particular technologies being taken up at the moment. And the whole system stuff tends to be, as I said, the sort of work we did in stroke, which is, start with a deep understanding of what the problem is, bring that multi-professional community together that's kind of credible, has the right skills to design what the solution needs to look like. And then it is a bit like that kind of implementation planning, where you can start using some of that implementation science frameworks to think through. And then what you generally find is you can't do a year prints to lovely project plan. It's very much in a staged, I always sort of do, let's do the first few, even sometimes weeks, and then review the plan and do it again. And then, or it might be you do your first 3 months and then you do a milestone, you stop, you pause, and you plan again. So I think that sort of agile management, and yeah, and then it's all that kind of risks, issues, logs, and that sort of thing. But yeah, I'm not aware of specific frameworks that certainly that I use, other than that kind of general approach. Sorry.
That's all right. We do have a particular thing within the Institute of Health and Social Care Management around change management and how you win people around to actually, as you put it, Amanda, doing innovation as a team sport, which, by the way, is probably going to be the title of our new book that we're going to write together.
Nice.
Don't know anything about it at the moment. Anyway, that's that. Hazel, may we come to you, please?
Yes, I'm off mute, aren't I? Yeah.
Yes.
Hello, Amanda. Hello,
Hi,
Amanda
Hazel.
and John and everybody. Nice to be on here. I'm one of the general public, so I'm not a specialist or an expert in any of this stuff. But one of the things as a member of the general public I perceive, rightly or wrongly, and I fear, is that there's silos. Whether it's a silo because it's stroke versus cancer versus another disease, or a silo because it's South London versus Oxfordshire versus West Midlands versus Scotland, when we as the general public, all we really want to have is a good level of care and service at the point of need. So I suppose my question is, to what extent is this massive jigsaw puzzle that the health service and care services all are, to what extent does that all get joined up at the top? What is the conduit for all of this being joined up at the top so we're not reinventing the wheel all over the country?
Yeah.
I'll let you have a go at that, Amanda.
Yeah. So I think there are now systems. So there are different mechanisms in place. So you have integrated care systems, which I think are a very good thing in terms of helping. They are about partnership work, and they are about bringing health and social care together across, quite large geographies. And I think that's a great start. And they still are relatively new. They've gone through significant management changes. So it's been a tough time for them, but their ethos purpose is absolutely right. And they are working hard to bring different parts of their systems together. And then at a regional level, the regions are trying to, like London region is bringing those 5 integrated care systems in our patch together. You've got the health innovation networks. We've got 15 that provide geographical spread across the country, and we all collaborate together and share learning. We've got a national pipeline of 3,000 innovations that we're all engaging with. So if I want to do something on automation in primary care, or one of my hospitals says, I don't know what to do about digital in peri-op or something like that, I can go onto that database and say, where's it being used? What can I learn about it? Who do I need to have a conversation with? So that we're trying not to do that reinvention of will. And then there is also a lot of, obviously, there's clinical networks across those clinical networks regionally that come together. I know they can sometimes be in their silos, but we are starting to see more of these clinical networks coming together, like cardiometabolic, so not just cardiovascular, but also thinking about diabetes, weight management, renal, respiratory. So they are starting to come together and realize that people have multiple conditions, and we can't treat people as a series of silos. We have to treat them more holistically. And then we are increasingly getting our data infrastructure intact, and that allows us to look at large systems and populations and to understand our variation in care, which the data is, in the same way as the kind of patient voice and that multidisciplinary approach, data is a great driver for change and realizing you don't want to be in the bottom quartile of things, particularly when it comes to safety and outcomes. So that can drive people to work together to say, well, what were they doing down the road? Because they seem to be in the upper quartile for this, whereas we're really struggling. So that data piece is hard to argue with and ignore. And once again, helps us to learn, drives us to learn from each other and improve. But yeah, I hope that sort of makes sense.
That's fabulous, Amanda. We don't have any more time anyway. We're out of time. Can we just... Amanda, I love meeting with you. Every time I meet with you, I learn something new.
Ditto, John.
And it's been a joy to have you as our keynote opener to our conference.
Thank you for inviting me.
It's just been special, so thank you so much. I know you did a little bit of research work to prepare yourself to come on. It really shone through. So Let's
Thank
all
you.
hear it for Dr. Amanda Begley, please.
Thank you very much. Lovely to see you all. And thanks very much to Jade for all their organisation and help in getting me
Queen
here.
of
So thank
virtual
you.
conferencing. There we are. Thanks, Amanda. Lovely
Thank
to
you.
see you. Much obliged.
Bye-bye.